All right, let me quickly cut across to Sneha Modani, who's joining us right from the newsroom. Sneha is in conversation with Randeep Guleria. Over to you, Sneha.
Thank you so much for that, Nabila. Welcoming Dr. Guleria on the broadcast. Dr. Guleria is the director of India's prestigious All India Institute of Medical Sciences. He's also a member of the National COVID Task Force, a body which is deciding how to manage this pandemic, this infection that is wreaking havoc across the country. Dr. Guleria, thank you for your time here. First of all, I want to begin by asking you, and that's what everybody is asking, when is this second wave going to be over? Because technically, if there is a peak in infection, then we see a decline also that starts. When is that peak really expected, sir?
So if we talk of the second wave, like we saw in the first wave, there will be different parts of the country which will peak at different times. I think we're already seeing that the peak has happened as far as the western part of India is concerned, with cases now stabilizing or declining in Maharashtra. Hopefully in the central part of India, that is in Delhi, Punjab and the surrounding states, in the next few days, hopefully in the next 2 weeks, it will stabilize and cases will start coming down. But we may have rising cases in the eastern part of the country. So we need to follow this up closely. But I'm hopeful that as far as central India is concerned, somewhere by the middle of this month or the later half of this month, we should see a decline in the number of cases. A lot depends on how aggressively we follow COVID appropriate behavior, because the cases are dependent on the spread of the infection. And if all of us work together to break the chain of transmission, the cases will come down earlier. If we don't do that, it may last for a longer period.
Yes. You know, Dr. Guleria, there is a projection that has been made by this team that has been constituted by the government. The projection is that before the 7th of May, there's going to be a nationwide peak. Do you agree with the findings of this team?
So my own feeling is that we've had a lot of projections in the last 1 year. Modeling has been done, but none of them has been very accurate. And that's why one is very careful about looking at modeling data. One must accept 2 or 3 things, that all modeling data are dependent upon very large number of variables. One variable is people's behavior. The second variable is the virus itself. The virus is now more infectious, spreading more rapidly, and therefore we need to keep that in mind. If we are able to have some sort of restriction in activities, COVID appropriate behavior, then possibly this month we should see a peak and decline in the number of cases.
You know, Dr. Guleria, you did mention that you're expecting cases to increase in the eastern part of the country. Does this include the northeastern part of the country as well? And also tell us, by the eastern part, do you mean by and large Bengal? Because this is a state which has seen the culmination of elections and the possibility of the cases now spiking there. Is that something that you're expecting?
So number of cases are already increasing in Bengal, in Odisha, and we're also seeing that in Assam. So this is a cause of concern. And as there is travel still happening among these neighboring states, there is a likelihood that we will see a rise in number of cases. In the neighboring country of Bangladesh also, there is a huge spike in the number of cases, and therefore there is a likelihood that this may also contribute to increasing cases in this region.
Dr. Guleria, you know, if you look at the technicalities of how this work of the behavior of a virus, a peak essentially also means that the cases will start to decline. But you're not ruling out a third wave also. That is something that can be a possibility, isn't it?
Yes, you must understand 2 or 3 things. One is, how quickly can we vaccinate individuals so as to give good amount of immunity? Second is, how does the virus change? If the virus evolves further and it develops what we call an immune escape mechanism, that is, the immunity that people have developed becomes less effective and then you can get infection again, then there is a chance that we may see a third wave. We will possibly see another wave, but I'm hopeful that by that time, because a large number of people will get vaccinated, the wave may not be as big as the current wave that we're seeing, and it may be a much smaller wave and it'll be easier to manage, unlike what we're seeing nowadays.
Dr. Guleria, you know, just to tell us, are you happy with the way the vaccination drive has panned out in the country? The pace of it, the manner in which this could have been done, more inoculations. Do you think we could have done much better than what we're doing right now?
No, I don't think so. You see, the issue here is an understanding of the supply and the demand. The demand is much more what the supply is. And we must understand that we are a huge country. Our population is equivalent to the population of many countries in Europe combined. And therefore, for us, it's going to be a big challenge. And therefore, we will have to vaccinate in a prioritized manner. That is one. And that is what we have done from the very beginning, that we've looked at the high risk groups so that we can save lives and actually decrease our mortality, and then gradually brought it down as far as the age is concerned. Secondly, we also need to really look at strategies of increasing our vaccine pool. So getting more and more manufacturers, getting more products or more vaccines into the country is something that needs to be done. That is something that we need to do more aggressively, and possibly need to work more on that area, so that companies which are having approvals from, let's say, WHO or from the FDA or from the European agency, can be sort of facilitated to bring their vaccine into our country and add on to the vaccine pool. They could also be tying up with manufacturers in India to manufacture the vaccine in India, so that we have more and more doses available. I'm hopeful that possibly in a month or two, this will happen, that we will have a large number of vaccines available, and the drive will really pick up in a big manner as far as vaccination is concerned.
You know, Dr. Guleria, as early as the month of August and September last year, we were having a conversation about Pfizer approaching the regulators. Do you think the decision that the regulators have now taken, apply for emergency use authorization, a decision is going to be taken in 3 days, carry on with bridging studies, this could have been done earlier, we could have saved more lives?
So one, it's always sort of simpler to look back and say retrospectively this would have been better. One could always argue that retrospectively, if we had done away with the bridging studies in the past and said that you can just approve vaccines with the regulatory approval being there from, let's say, the foreign regulators, we should accept that and go ahead. But then there was a lot of concern that in our own population, we may have side effects which may cause problems which which may not get picked up. And if that approval was given, then people would start criticizing the regulator for giving approval which were not really justified. The same thing
Okay.
happened with the Covaxin. If you look back about in January, when Covaxin was given approval, it was criticized a lot by a lot of people who argued that the emergency use authorization should have been given much later on with more data in. So I think if we look at the mechanisms, the regulators have tried to follow a fine line, but retrospectively, possibly we should have tried to do this more aggressively. But like I said, even in the scientific community, there was no sort of consensus, and even for Covaxin, there was a lot of argument for many days that why did we allow it to be rolled out, and now everyone agrees that it was a good decision.
Dr. Guleria, what information is there that you can share with us about each of these variants, especially the double mutant variant, increasing cases in the country and leading to more severe infection? What's the information with you?
So what I like to say is that if you look at the epidemiological data, then although we need more and more lab-based data to support it, definitely it seems that the variants that we're seeing in our country, the double mutants or the UK mutants, are all more infectious than what we had seen last year. The virus is spreading at a much more rapid pace than what had happened in the past. The curve itself is so sharp; it's almost vertical as compared to what it was last time, when the number of cases rose in a much slower manner. We can't keep blaming this only on lack of COVID appropriate behavior. There has to be some
Yes.
degree of change in the virus as terms of its virulence is concerned. As far as mortality is concerned, I'm not sure. We're seeing large number of deaths. There's no doubt about that. I'm not sure whether we can say that this is due to the virulence of the virus. It's possible, but we need more data. It's also possible that this is just because of the number of cases. If we say that the mortality is say 1 to 2%, but when you see 1 lakh cases, 1 to 2% is less than when you see 4 lakh cases. The 1 to 2% becomes much more in absolute numbers. Also, because of this huge surge in cases, definitely one has to admit that there is some degree of decrease in the quality of care that is being provided because of the number of patients rushing into the emergency and doctors having a tough time. And that may also be affecting morbidity and mortality.
You know, Dr. Guleria, you do say, and you do say that that we do require that there is a possibility of a wave. That's the nature of the virus essentially. But did you expect that the wave is going to be so ferocious that we'll see up to 4 lakh cases and more in a single day? No country in the world has seen so many cases in a single day.
Correct. So when we looked at it, and this is something that even history told us, if you look at the 1918 pandemic, the second wave was much more ferocious than the first wave, but it was linked to sort of decrease in the appropriate behavior. But somehow we felt that because of our preparedness and because of vaccination, maybe the wave would not be as sharp as what we saw. And therefore, this acute rise in the number of cases, not only in terms of number, but the rate of rise, really has caused a huge strain on the healthcare system and really caused a lot of concern to people because the number of cases has gone up to 4 lakhs. But if this number had happened over a few weeks or a few months, we would have been able to manage it. But the number has jumped from 10 to 20,000 to 4 lakhs in a matter of a few days or just about 2, 3 weeks. This has caused a huge strain on the healthcare system, which I think is really causing a major problem in terms of oxygen beds, ICU beds, and hospitals struggling to care for so many patients who have suddenly become sick.
You know, Dr. Guleria, you mentioned hospitals. We've been speaking to just so many doctors, and most of them say, just shut down the country, we are done. You know, we've had instances of doctors taking their own lives, doctors, you know, dealing with death day in and out, and they say, we need a breather, we cannot handle this anymore. Do you think, in the interest of doctors, in the interest of the people of the country, to save more lives, to improve the healthcare infrastructure, a nationwide shutdown of the country is required now?
So I think we need to look at three things. One is, of course, improve the hospital infrastructure, which we're doing, oxygen beds and other things. But the second most important thing is to decrease the number of cases. We have to break the chain of transmission. This is a virus which spreads from one human to the other. It's a human to human spread. If we decrease close contact between humans, then the virus cannot spread to another person and the cases can come down. And therefore, a strategy of stopping this has to be done. We can call it a lockdown. We can say it could be a regional lockdown based on a graded response, which UK did, depending upon what is the criteria that you want. We could say that if your positivity rate is more than 60%, more than 10%, if more than 60% of your beds in a place are already full, that means you're now coming up to full capacity and you will not be able to manage more patients. You should have a complete lockdown in that area. Whether it's at a state level or the larger level is something that policymakers need to decide because it's an issue of organizing everything in terms of lives, livelihood, seeing that transport and essential services are maintained, and at the same time, looking after those people who are the daily wage workers, the laborers, their care is also looked after. So that has to be done. But I do agree that we cannot just continue to focus only on infrastructure and hospitals unless we also focus on decreasing the number of cases in a very, very aggressive manner. So if you're talking of a lockdown, it has to be for a sufficient duration for at least 2 weeks. It has to be aggressive. It's no point having a weekend lockdown or a night curfew. And secondly, we must really look at how things evolve and then take a sort of a strategic approach. We can unlock early if it's needed, depending on how the cases pan out. At the same time, the third thing that we need to do is try and roll out the vaccination as much as possible. More and more people who are eligible should come forward and get themselves vaccinated because that will also help in decreasing the number of cases.
So, Dr. Guleria, if I got you correctly, you're saying let's have a more aggressive sort of a strategy. Don't do this this weekend lockdown business. It doesn't really work, you know, locking down for 2 or 3 days. Have a lockdown over a period, but at the same time, keep in mind that if there is a nationwide lockdown, there will be people who will suffer economically, and the government must be prepared to take care of them. Is that what you're saying?
Exactly. So we need to look at what the lessons that we learned from the last
Yes.
lockdown, see how we can implement them, see how we can make sure that essential services, especially for hospitals and other things, are maintained, whether it be oxygen supply and other things. Also, see that the laborers and the daily wage workers are looked after, and at the same time, have an aggressive strategy that there is the chain of transmission is broken. There's no point having a week down lockdown and then during the day, during the week, everyone can mix together and have get-togethers and parties. The whole purpose is lost.
You know, Dr. Guleria, a couple of doctors that I spoke with said that, you know, let's not do this over such a long period of time that people suffer. Let's do this, say, for 2 weeks flat, a nationwide lockdown for 15 days, so that even the doctors get time, the cases come down, the deaths come down, and then we can get back to just having a graded sort of an approach towards restrictions. Is that something that you think is feasible right now?
Yes, that is feasible. That is being
Okay.
propagated across the globe, what is known as a hammer and dance policy, that you come down aggressively with the hammer in terms of strict lockdown and other things. Once things are better after 2 weeks, you start gradually opening it up. But if they worsen, you again have used the hammer. So it's a hammer and dance sort of a strategy where you are looking at a strategy of aggressive lockdown and then evaluating and then opening it up after some time as things become better. It also will
Okay.
allow the infrastructure to really gear itself, because if you are able to have a lockdown and cases come down for some time, hospitals will get time to really sort of get ready. The camp hospitals or other hospital and other facilities will get time to get themselves ready, which we have not got time this time when the spike happened, because it was so sharp and in such a short span of time that it is really causing a huge strain on the healthcare infrastructure.
Okay. Dr. Guleria, a couple of other questions. And, you know, you keep on speaking with the press. You appear before the press often also. But there are many questions that people need answers to. A lot of people want to know that if I have had the virus and if I recover, how soon can I go for my first shot or even for my second shot? What's the duration that you then suggest somebody should wait before taking a shot of the vaccine?
So what the guidelines usually say is that you must wait for at least 2 weeks after you're completely recovered. Some physicians would say that you could even wait for 4 to 6 weeks so that your total recovery has occurred and you can take the vaccine. So minimum 14 days, but can be up to even a month or a month and a half.
Month and a half, and this delay is not really going to affect the efficacy of the vaccine, is what you're saying.
No, the delay will not affect the efficacy of the vaccine. If for some reason your second dose has got delayed by a few days or by a few weeks, don't worry. It's not that the booster effect will become less. The vaccine, the second dose will have a booster effect and you will get good amount of antibodies.
Taking the vaccine on time after your recovery. Say I have a negative test right now. I'm a patient. I have a negative test. If I'm due my vaccine after 3 days, can I go for it or should I still wait for 2 weeks, sir?
So if you have recovered and totally from a COVID infection, then 2 weeks after you have recovered is an ideal time to take the vaccine, at least 2 weeks after you recovered.
Okay, 2 weeks, good time. Dr. Guleria, a lot of people now are waiting for negative RT-PCR tests after being tested positive for 14 days, 20 days. There is pressure on the system. Is a negative RT-PCR test even required, or is that something that can be done away with?
The guidelines are very clear that for patients who have mild disease or are asymptomatic, if you have crossed 10 days of having no symptoms, if you're asymptomatic, or you've crossed 10 days and you've had no fever for the last 3 days, then you are non-infectious, you can go out, you don't need to get yourself tested. Only those people whose immunity is low, who are on immunosuppressants, who are on regular chronic dialysis or such thing, there the virus can stay for a longer time, and then after 2 weeks you may get yourself tested. But others don't need to get tested. So majority of people don't need to get tested if they are asymptomatic and have been afebrile for at least 3 days.
There is already pressure on the system. A suggestion from the Lancet Commission task force is that states should not be pressurizing the people coming into when there is interstate travel to get a negative RT-PCR test. You think that's a valid suggestion?
I think it's a very valid suggestion. The virus is now having widespread community transmission. Now having these things are actually irrelevant. Therefore, asking people to get a test done before coming is of not much use. And we must understand that many people may be in the incubation period. They may be carrying the virus. Their test may be negative right now, but they may become positive 3 or 4 days later. And by that time, they would have been inside the state and would be positive and infectious. So this has two disadvantages. One is you're missing these cases. Secondly, you're giving them and everyone a false sense of security that this person was negative and therefore he does not need to have COVID appropriate behavior and he can go around in the community. So I don't think this is required.
Okay, that's a very valid suggestion because even yesterday, for example, like a state like Punjab said, no entry into Punjab without a negative RT-PCR test. Is that something that you'll ask the states to do now, not to insist on a negative RT-PCR test, Dr. Guleria?
I think that is important. We must understand most states are porous. It's not that you have, it's like an international boundary. People will go into the state from so many roads or passages across the state. And therefore, to have insist on this is actually not of much use. Secondly, like I just said, a person who's negative doesn't mean that he's going to be negative. He may still be in the incubation period. And we should look at it as one country rather than trying to be so restrictive because it doesn't have a value in the long term.
Okay. Fair argument. Dr. Guleria, lots of questions being asked about high-rise apartments and how there is a possibility that the virus is in the fecal matter. Is the virus in our sewage, and is that a reason why apartments are seeing an increase, a major spike in cases?
So I don't think the virus has been picked up in fecal matter, and there's no doubt about that. But the virus does not transmit through that route. So fecal-oral route is not a mode of transmission. It's usually aerosol. Apartments are seeing this because very often they have a common lift or common staircase. And if you have a person who is in that lift and who's sneezing or is coughing, he may release the virus in that, let's say, environment, which is a closed environment. And if someone gets into the lift later on, maybe about 5 minutes later, he may feel he's all alone and he may not be wearing his mask. He could get infected there. So it's important to understand that since this virus is not only a droplet infection, it's also an aerosol infection. It can stay in the environment for quite some time, especially if the ventilation is not good. And you may come into an area where you may feel that there is no one around you and therefore you are protected, but the virus may still be sort of in the air. And therefore you could get the infection if you're not having COVID appropriate behavior. That is why whenever you're outside, even if you're all alone, please wear your mask and be very careful.
And if you know that there is nobody who could have contracted the infection possibly in a household, does one still need to wear a mask, especially around elders, senior citizens?
So if you're around elders and senior citizens, since we know many people may have asymptomatic infection and the elderly are at a high risk group, if you're looking after your elderly, it's important that it would be advisable that inside the house also you could wear just a cloth mask or a simple surgical mask, just and wash your hands regularly so that you don't give them the infection even if you're asymptomatic.
You know, I just want to ask you, some viewers are putting these questions. Post-vaccine, a lot of people get fever, many symptoms like COVID. How long before they should step out as the immune system is under attack? So if I'm negative, should I also, if I've got the vaccine, can I step out? Is there a problem if I step out?
So if you got the vaccine for 1 to 2 days, you could have fever, body aches, fatigue, pain at the site of injection, but it usually settles on its own. Sometimes you need to take a tablet of paracetamol. It doesn't mean that your immunity is low and that you are more prone to getting the infection. You can definitely step out, but COVID appropriate behavior has to be followed. And now when we're seeing such a surge of cases, I would say only step out if it's essential. Otherwise, try and stay at home as much as possible.
Dr. Guleria, you mentioned in the press conference yesterday that, you know, having a CT scan is equivalent to exposing yourself to radiation of 300 X-rays, which is not advisable. But let me tell you that there are doctors right now who are telling patients, go and get a CT scan done and then come back to us so that we can help you give the appropriate line of treatment. What does the patient do? Because you have flagged this off that there is a concern vis-a-vis radiation exposure, but doctors are still suggesting that a patient do a CT scan.
So I'd like to repeat what I said and I'll just expand on that. One issue is that people who have mild illness, suppose you have just in the first few days of illness, you just have fever, your saturation is well maintained, 97, 98, you really don't have much complaints, there is no need for getting a CT scan. You're actually, especially in the younger age group, A young person exposing a young person to a CT scan with its radiation risk is definitely not worth it, and therefore there's no point getting it done. If you get go on, if that 10 you're in the 10 to 15% who go on to get moderate to severe illness, you're now having problems and your saturation is falling and you have other issues like your fever is becoming high grade, then yes, you are admitted and then you need to get a CT scan to see how much is the lung involvement. So that is something that is required if you have moderate to severe illness. But 85% of people have mild illness. They don't need to get a CT scan done. Getting a CT
Okay.
scan done is actually causing a problem for them. Now, there is one point that I would like to also add, that there are times when you have classical features of COVID, but your RT-PCR is negative. And some people then get a CT scan done to look at what we call a clinical radiological profile to say that, okay, RT-PCR is negative, this may be false negative. So if we get a CT which shows features consistent with COVID and the clinical feature is consistent, we can make a presumptive diagnosis of COVID and start the patient on treatment, especially if the person is having more severe symptoms. So there a CT may help in making a diagnosis. But if your
Okay.
RT-PCR is positive, there's no need to get a CT if you have mild disease.
Okay. Dr. Guleria, once again, I'm just going to come back to the question on variants. Genome sequencing as advised and as you all would have hoped for, 5% of all samples, but that clearly is not being done in the country. This is one weapon that we can use to understand how the virus is changing its form. Do you think a lot more genome sequencing needs to be done in the country given the fact that we've been hit by variants?
I think so. I think what we need to do is two things. 5% is a reasonably good number. It could go up, but we must understand that 5% of 4 lakhs is a very large sample size, number of people that you're doing, the samples that you're taking. But you should also take samples from areas, and that is also being done from areas where you're seeing a huge surge in the number of cases, just to see that is this surge related to any new variant. But that is not all. So you have to also look at the clinical and the epidemiological profile that is going along with this variant that you pick up. How is this variant that is being picked up, whether it be a double mutant, a triple mutant, or any new Indian variant? How is it affecting the clinical cases? Is it causing more infection? Is it causing more mortality? Is it more virulent? Or is it causing what we call immune escape mechanism in form of, is it causing reinfection, or is it decreasing the efficacy of the vaccine? So it's not only just picking up the variant, it's also then going ahead and trying to look at it, that is this a variant just of interest, that it is something that we picked up but it doesn't do anything, or is it a variant of concern, and does this variant actually cause some change, and does that affect our clinical strategy? So I think it's very important now as we move ahead to have a very aggressive strategy in terms of picking up variants, in terms of being able to analyze the data and to see how are they affecting cases, the mortality, and also the efficacy of the vaccine.
Dr. Guleria, in the first wave, there was very little scare about this infection being seen in 2-tier, 3-tier cities, rural India, but that's not the case this time around. In UP, in other parts of the country, also like Maharashtra, for example, the infection has reached the hinterland. There are people in UP who are dying of pneumonia-like illness because there is no way to do the test there. There is a severe crunch as far as the medical system is concerned. What is the Government of India's strategy to handle the spread of infection in rural India and the hinterland and ensure that less people lose their lives, more people get access to healthcare?
So I agree with you that we need to have an aggressive strategy, and multiple things are being done. First of all, like you're saying, that sometimes it's not possible, especially in rural India, to get a test or the RT-PCR test done. A rapid antigen test is still possible, but even if that is not possible, we could have what we call a syndromic approach, that based on the syndrome that you have in a pandemic situation, if you have the classical features suggestive of COVID, a treatment should be started so that lives can be saved. Also, what is being done is, and this is being done also at our institute with the Ministry of Health and Family Welfare, that we're trying to set up what we call centers of excellence, regional centers of excellence, and train doctors at a rural level, whether it be at a primary health center or practicing doctors, of how to go about diagnosing and managing COVID-19, because this is a new viral infection. And many people in the hinterland are not clear as to what they should do and what is the ideal time of starting various drugs. And that is why there is sometimes a panic and in a panic reaction, sometimes drugs get started which may cause more harm. So this is being done very aggressively. Every day we're having discussions with more than 1,000 doctors and trying to reach out to more and more doctors in rural India so that we are able to develop a treatment plan for them, both in terms of syndromic diagnosis and management as far as COVID-19 is concerned, and at the same time develop a strategy of triaging and shifting those who are more sick to a district hospital or to a higher level in terms of their morbidity and severity of illness.
Dr. Guleria, you know, the word mysterious is often associated and used for COVID-19. Is the mysterious nature of this illness stopping the scientific community from developing a treatment against this infection? Because right now, whatever medicines that are there is being repurposed to manage the infection. There is no one treatment. Why is that?
So that is true. We've made huge research as far as vaccine is concerned, but developing an antiviral drug has not been that rapid, and that's because viruses are always difficult to treat in terms of developing drugs because, like we've seen, they tend to change, they tend to mutate, and therefore you are really chasing the virus rather than developing strategies. But a lot is being done. There are monoclonal antibodies which have been made, which are against the spike protein and are able to work as antivirals in the early stage of the disease. Other drugs are also being looked at. So one is hopeful that in the next few months you may have a specific antiviral drug. Currently, this is one of the most challenging things that we have. That although we have drugs which we use, they are repurposed drugs. We don't have a precise or specific antiviral against COVID-19 that I can say you give this drug and it'll kill the virus and you'll get cured as far as the infection is concerned. We don't have a drug like we have for other viral infections. So this is something that we need to do. A lot of research is being done on this, and I'm hopeful that maybe sometime in the coming few months we may have some new drugs which will give us hope as far as treatment is concerned.
Dr. Guleria, you know, steroids and blood thinners are eventually helping save lives is what many doctors seem to suggest. Would you agree?
Yes, but it's very important that we understand when to give which treatment. COVID-19 is like a biphasic illness. It has two phases, and that's very important to understand. In the first phase, when you have fever, sore throat, cough, and cold, you just need symptomatic treatment. You can try some other mild drugs, which have been even in the guidelines, our clinical national guidelines recommend drugs like ivermectin, hydroxychloroquine. But 80 to 85% of people will just have the mild illness and recover. And in them, giving drugs like steroids may be more harmful because we know that in this stage, when the virus is replicating, steroids may actually sort of promote replication and make the disease more severe. And therefore, steroids should not be given in this stage. If those people who go on to the second phase, which is the second phase of the illness where the viral replication has started coming down, but now the body's own inflammatory response is getting dysregulated. We have a dysregulated immune response in the body. Here you need to give steroids, anticoagulants. You may need to give drugs like remdesivir and convalescent plasma. And majority of patients will respond and become all right. A small number may still go on to have what we call a cytokine storm. And in them, we need to give drugs like tocilizumab or other drugs. So the timing of
Okay.
drugs is very important. If we give drugs like tocilizumab early, it really will sort of knock out your immune system and you will be more predisposed to fungal infections, other bacterial infections, which may cause a higher mortality. And sometimes we see that. Therefore, I'm just saying that these drugs are useful. Steroids, anticoagulants are useful, but they should be given at the proper time. Giving them too early may actually cause more harm than good.
Dr. Guleria, why is that in this particular wave, so many people are getting so breathless? Why is the requirement for oxygen increasing in this particular wave? Because we didn't see this happen the last time around.
So last time also there was an increase in the need for oxygen in about 10 to 15% of patients. Two things have happened. One is, like I said, the rise is so rapid that we don't have that much of a turnaround time. Otherwise, if it was slow, then those people who had come to us on day one would have gone home and then the next would have come. This time we didn't have that much of time to
Okay.
really send those who had recovered back home to and then others to come. The number of cases came so rapidly. Second is the numbers actually. Again, like I said, if we say 15% of people require oxygen, if we had a number of less than 1 lakh a day, that 15% was manageable. But if you have a number of 4 lakhs per day, that 15% becomes much more. And if that 4 lakh happens over a few days, then the number of people who require oxygen in that short span becomes huge. So it's actually, that is the reason why it's happening. I don't think it's that we are seeing now more lung infection, but we do need to look at that. A lot of people are looking at the data more critically to see whether this is the variant is causing a more what we call low respiratory tract infection, because viruses at times develop a strategy of then going quickly into the lungs rather than just staying in the nose and throat. Currently, it seems that that may not be there because it is still a coronavirus, which is mainly in the upper airways. But
Okay.
that is being looked at because, like you said, we are seeing more people requiring oxygen. But I think it is also just numbers rather than actually a percentage increase in the lung infection.
All right, lastly, Dr. Guleria, what do your sero surveys suggest and how significant should we take are these sero surveys right now, given the fact that the virus is mutating? What percentage of the population is yet to have been exposed to this infection for us to then gauge and understand what is the possibility of them getting infected in the near future?
So sero surveys are useful. They give us some idea, but I think we should always look at them critically with a little bit of pinch of salt, because we must remember that sero surveys will do a survey of the current circulating variant. If the variant changes dramatically and is now developing an immune escape phenomena and therefore causes a higher chance of reinfection, the sero survey may not be that useful.
Okay.
However, having said that, the current data that we have does seem to suggest that the reinfection rate in our country still continues to be low. It's not that high. So one is confident that both in terms of people who've had past infection and who've got vaccination, chances of severe infection will be less. But we are seeing some people who are having infection again, who had got infection last year also. So it has to be looked at very carefully. I would say surveillance data are helpful, but they cannot really guide treatment to a large extent, because if we said the sero survey in Delhi showed that more than 50 to 60% people were had already got infection, then that data would suggest that we are already achieving herd immunity and we should not have seen so many cases in Delhi. So I think we need to be very careful how we interpret sero survey data.
All right. Dr. Randeep Guleria, thank you so much for your time. Thank you so much for your perspective. Very, very valuable perspective. Important things that you've said regarding the standard protocol being the same as far as hand hygiene, mask is concerned, because that eventually is going to help us give some amount of protection. Thank you, Dr. Guleria.
Thank you.
All right, with that, it's time for a quick break here. Much more news in just a bit.